Alright, so this video is about opioids. Opioids are derivatives of opium. In fact, they're synthetic. That's usually what makes a difference between an opioid and an opiate. We use opioids in veterinary medicine. Their main goal is to produce analgesia and sedation. Mixed with other drugs like an alpha-2 agonist like dexmedetomidine, they can actually be used as induction. They're classified as agonist, partial agonist, agonist, antagonists, or straight full-blown antagonists. Agonists like morphine, hydromorphone, oxymorphone, fentanyl, and methadone are all considered pure agonists. A pure agonist stimulates the mu receptor in the body. A mu receptor is one of the three receptors in the body that are present that produce the effect that we see when an opiate is given. Partial agonists like buprenorphine, which is a very strong partial agonist. Agonist antagonists like butorphanol and nalbuphine, and antagonists like naloxone, atropine, and carfentanil. Opioids are controlled substances. It's really important to understand that. Please make sure that you understand that. Everything except for an antagonist. You have to remember that antagonists, their goal is to reverse what an agonist does. Okay? They bind to and don't stimulate a receptor. Opioids are essentially can be given any possible way you can think of, and that makes them very useful in veterinary medicine, and they also have a very wide margin of safety for the most part, which is great also. Alright, so they mimic endogenous opioid peptides, so that once again they mimic the natural opioids that would be in nature. They have analgesia and sedative effects. The result of action is the receptors on brain and the spinal cord, and there are those receptors that I just briefly mentioned beforehand, mu, kappa, delta, and there's other subtypes, but the main three ones that I want you guys to focus on are mu, kappa, and delta, with mu being the most important and most profound one in the body. Each opioid has a different action at its receptor. So agonists bind to and stimulate mu and kappa receptors. That's really important, mainly mu receptor. And this is best for moderate to severe pain. So if we give a pure mu agonist, we know we're giving it to control pain. Partial agonists bind to and partially stimulate receptors, so they don't produce the more full-blown sedation and analgesia that a pure mu agonist would, but they usually do a pretty good job. Agonist antagonists, they bind to mu and kappa receptors but do not stimulate only kappa receptors. They do not stimulate the mu receptor. Once again, remember that the mu receptor is the most powerful receptor in the body. Antagonists bind to but do not stimulate mu and kappa receptors. So general effects on opioids, it usually is dependent on multiple factors, but there's a general understanding of most opioids that they do cause sedation. At high doses, they can cause narcosis, which is a sleep-like state. Refer to chapter 1 in your book in that. Cats, horses, and ruminants, they can cause CNS stimulation and bizarre behavior patterns like dysphoria. There is such a thing in cats called morphine mania, and generally speaking, we can lessen these effects by using a lower dose. Analgesia, there's that pure agonist again. They are absolutely the most effective against severe pain, and they're used predominantly as a pre-medication due in painful surgery, which most surgeries are painful, so this is one that doctors reach for a lot. Cardiovascular system, they can have bradycardia. Usually it's not profound bradycardia unless it's mixed with other drugs. When it's mixed with other drugs, we can have profound bradycardia. And the respiratory system is usually dose dependent, but it's usually pretty minimal anyway. All right, so other effects, meiosis in dogs, which is widening of the pupils, mydriasis in cats and horses and ruminants, which means meiosis is pinpoint pupils in dogs. Mydriasis in cats, horses, and ruminants, that's where the pupils get very large. So meiosis again is small pinpoint pupils. Mydriasis is large pupils. It can cause hypothermia in dogs and hyperthermia in cats, which is a strange thing, but that's just the way dogs and cats operate differently under these drugs. They can have increased responsiveness to noise. This is one of the things that I look for whenever I see a dog sedated with a drug like hydromorphone. As soon as I take that dog outside, a lot of times they will start to bounce their head around because they are sensitive to the cars driving around, or maybe even the squirrel up in the tree, something like that, and they're oversensitive to the noise that's coming through. Horses, you can get profuse and profound sweating. And a decrease in urine production with urine retention. This is a common thing whenever a drug like hydromorphone or morphine is given in the epidural route into the spine. CNS, you can have anxiety, disorientation, excitement, and dysphoria. Cardiovascular system, you can have pronounced bradycardia. Respiratory system, you can have decreased respiration and tidal volume. Remember, tidal volume is the amount of air that flows in and out of the lungs in a single breath. It is really dose dependent, and you can see at the bottom there it says a ceiling effect with some agents. Essentially, a ceiling effect means that the animal can only get, and this is kind of sounds a little bit strange but true, so high off this medication. The animal can only get the effect of the drug could only reach a certain point in the body, and then it cannot go any further, okay? And that drug is buprenorphine that does that. GI system, initially we can have salivation and vomiting in small animals. Initial diarrhea, vomiting, and flatulence is very common with the pure mu agonist drugs. And generally speaking, we pre-treat these guys with atropine, which is an anticholinergic to help increase the heart rate, and acepromazine. Acepromazine can have some antiemetic or anti-vomiting effects. GI stasis follows the initial GI stimulation. So in other words, the gut starts moving really, really quickly initially whenever the opioid's given, and then afterwards it actually will slow down. Generally speaking, a lot of doctors will avoid administration with any animal with a confirmed GI obstruction, but I have seen doctors use these powerful opioids even when an obstruction is there, as long as they're going directly into surgery right after the drug has been given. Alright, so other adverse effects, obviously addiction, that really comes down to us as people and making sure that we keep these drugs safe and away from people that might have physical dependence from these drugs. Rare occasions we can have an anaphylactic reaction with facial swelling and hypotension, although that is very rare and I've never actually seen that. Certain cases, maybe with head trauma, a doctor may avoid using these drugs because of intraocular and intracranial pressure. And there are certain drugs, usually in the realm of antidepressants, that we need to make sure an animal's not on before we start giving opioids. So main use of opioids is a pre-anesthetic. You can see that there's a list there: agonist, partial agonist, and agonist-antagonist. That's the most common. And usually they are mixed with other drugs, i.e. a tranquilizer or an anticholinergic to increase that heart rate. And the main thing is analgesia, right? We prevent and treat postoperative pain, and we usually do this before the pain has actually been induced, i.e. before the surgery. Anytime we combine it with a tranquilizer, it is called a neuroleptoanalgesic. Okay, and that's really important. And that is our word again: profound state of sedation and analgesia induced by simultaneously administration of an opioid and a tranquilizer. The hospital I work with now uses acepromazine and hydromorphone mixed in a syringe, and that is a neuroleptal analgesic. So you can see our list of opioids v. tranquilizers there. I'm not going to get into every single one in this video. Generally speaking, we use neuroleptal analgesics and sedation for minor procedures, and sometimes in induction of general anesthesia in dogs. It should say in young healthy dogs, but we usually don't do it as much in cats. Cats usually get straight opioids, not mixed with anything else. Anytime we use an antagonist, the goal is to reverse the undesirable effects. We are trying to wake up a patient following sedation, although I will say most of the time these opiates are used in painful procedures, and we don't want to reverse them unless we absolutely have to do it. The most common one is naloxone, and unfortunately there may be some people that are watching this video that may have it in their house, and it's not due to anything in veterinary medicine. It is what's used to usually reverse a heroin overdose, unfortunately. Naltrexone is another one, but this is usually used more in wild animals, and it's much longer lasting. So with naloxone, the mechanism of action is unknown. They do know that it blocks mu and kappa receptors. They don't know how it does it, which is the case with a lot of drugs, if you guys have already started to figure out. In an IM injection, it is 5 minutes to reversal. I will say if we grab the naloxone off our shelves, it's usually to give it IV, and it works a lot faster, usually less than half the time. And the duration of action is 30 to 60 minutes, which means the animal may need to be redosed before the drug wears off. Generally speaking, reversals can be completed in a few minutes, and they reverse just about everything. Adverse effects are extremely rare. Rare occasions you may see excitement, anxiety, and things like that, because you are going to be stimulating the sympathetic nervous system or the fight or flight nervous system. So think of an animal that's in a fight or flight response, and that might be something that you see. And a lot of times we can prevent this by using an agonist-antagonist, which is, remember, an opioid that has antagonist effects on the certain receptors, usually mu and kappa, but stimulates delta at the same time. And this is a way that we can still provide pain medication and reverse the more painful, and reverse the more powerful opioids at the same time. Generally speaking, we use these for emergencies. Somebody that said that their dog ate their heroin stash, and yes, you will probably see that. Accidental overdoses for us can happen. Anytime we want to reverse a neuroleptal analgesic. And reviving neonates after C-section, if the mother received opioids, some opioids can cross the placental barrier, and that's why we would want to use that. And we would place 1 drop under the tongue. All right, that's our talk on opiates. There'll be more of a talk in future conversations. Thank you.